I had promised you at the beginning that the whole point of this really is to get all of you talking, because that's what actually will kind of get everybody engaged, wake you up, and create a conversation. So there are a couple of strategies here that I think we can take to do that. First is that during lunch, I know that there were several conversations that took place, and I saw handwritten notes at many tables, which means that people actually followed instructions and they did what they're asked to do. So I'm wondering if we could have maybe a few folks stand up and just say a little bit about what was discussed over lunch in those wonderful handwritten notes, which, by the way, we would like to get a copy of. In the modern way, you can just take a picture and send it to us, or you can hand us the physical piece of paper. So first, maybe barriers and needs in workforce development. Although I didn't see a lot of hands for that, it turned out there was a table actually talking about workforce development. I'm curious if anybody from that table happens to be present and willing to just say a few words about what was discussed. Please.
We were closet workforce development people. We didn't want to come out right away. Just came to the table.
All right. Well, there's a mic right there. If you.
My name is Sally Cherry Consulting Network. Who's also a 3D emergent virtual world developer. We went over various needs and barriers, and to my table mates, if I leave anything down, please chime in. We were talking about various needs to retrain people, recurrent training, because quite often, as new technology, as technology comes out, it's being redeveloped or being added on to, so that recurrent training is a part of that training to stay up with technology. Too often people think, okay, this is in place, but it doesn't stay in place. There's always a new version coming out, so that recurrent technology is key. Empathy training for individuals working with the aging population. Health education to discuss the various issues. Too often, people who may be coming in contact with that population are not fully aware of some of the issues related to the various health conditions. Customer service, staying in contact with both components of that community. Maybe your care provider, your administrators, your medical professionals, or whoever's in that network. The barriers we went over was the lack of out-of-box thinking. A lot of times you need some thinking or some solutions that's not your traditional solutions. But you have to kind of think out of the box or something that we haven't tried before. It might not work well. If you have nothing else on the table, give it a try. Child care centers came up possibly as another barrier for that training. Because a lot of times people will not come to it because they don't have any child care. Support for the nurses and the rest of the medical team. Too often there's not enough support. Because people don't realize most facilities it's a 24-hour shift. 7 on, 7 off, and there's always someone coming in. And too often that does not allow for that training. So you have to get creative about find some time slot, get that training in here in some kind of way, maybe technical, whatever. You get that training done without it pulling from your care that you provide to your clients. The comfort zone. Sometimes people are intimidated by new technology or technology period, or even just turning the computer on. Some people are intimidated. So what else be one of the barriers that has to be overcome? To overcome computer technology illiteracy. And that was one of the key ones we talked about, and educational qualifications of the individuals working within this field ecosystem, dealing with the aging population.
Thank you. There are a couple things I think kind of interesting you mentioned, particularly in the technology space. So one is this notion of velocity of change. I mean, in some sense, the technology industry has been built around high velocity of change, because that's in some sense what you sell as change. But when you're thinking of engineering toward an aging population, you may not want that velocity of change anymore, simply because it goes against what you're actually trying to achieve ultimately in the end. I think that's.
I think those basically because the workforce up to date of what is going on, so they can kind of incorporate in that maybe, and not necessarily with the client-directed interaction, but maybe professional, peer-to-peer within a professional setting interaction.
Mm-hmm. The other thing that it sounds kind of popped into my head as you're saying this is this notion of could you actually start to create essentially a Coursera for care for older adults, for example. I mean, right now, what do? You probably go on YouTube and you find, a how-to video to do X, Y, or Z. That's how I do almost anything these days. But could you actually maybe structure that in an organized way, and you could actually imagine taking people through some types of stages of retraining or education? Interesting ideas, thanks. Any other comments from the audience? All right, industry innovation. There are actually two industry tables. There was a table and a sub-table. I'm curious if the table...
Michael was...
Oh, okay.
You got drafted, okay.
Hi, my name is Aaron, Hopkins alum and entrepreneur now. So some of the things we discussed in terms of barriers from an industry perspective is, I guess, just this perception from companies that there actually is an opportunity here. So it's not quite there all the way. So that's one barrier. The other side is just the regulatory landscape is complex. And we discussed different sort of thresholds of regulatory barriers. So there's, on one hand, there's just the wellness space, health space, and then medical space. And so as you go in that direction, the increase in regulatory risk and the barriers get more complex. Other question that industry was challenged with is figuring out who's paying for the innovations to make. Healthcare is complex. Who is the payer, provider, or the patient? And figuring out the value economics that follow that business model. The other was more or less for the marketing side. You mentioned, I guess, the shift towards the life plan communities. And there's this shift away from any terms, marketing terms that mention aging or facilities. So some of the negative connotations that come with that. Also, I guess one big thing we talked about was the need for embedded industry within academia. So one of the doctors was saying how he wants to be able to call up an entrepreneur or a biomedical engineering sort of expert just as he would call up a pharmacist. So treating engineering and industry expertise to that same degree of prestige and utility in the healthcare environment. And lastly, I think it's just a general sentiment, but turning prototypes to products is just art. And so there needs to be more sort of the starting energy is good at Hopkins, but sustaining energy really needs to be there to really push these things through.
Mm-hmm. Thank you. I don't know, did you want to add anything from our sub-table? We had it was the kids' table.
Yeah, so Maj and Greg and I were the kids' table, the card table. We talked about the challenges really being every effort or venture to create a new solution. You got to start with a problem. You got to be solving a painful problem. Ideally, a painful problem for all the constituents, and there are multiple constituents in the healthcare system: patient's family, the caregivers, the healthcare provider, the payer, and they're different people. Because unlike most markets, the person who benefits from it, the person who pays for it in this market. It needs to be a big problem, a painful problem that a lot of people have. It's a street market, and the way to reach those people. And as the other group said, somebody's got to be willing to pay you to solve that problem. We also talked about, Hopkins is, world-class, research and academic and medical facility, and, there's so many discoveries and inventions and IP that have been created in their labs and the clinics here. It's difficult, though, to kind of translate that, to leverage that, to use that to build a viable business where someone's paying you for it, you're taking it to a mass market, and that's something that Hopkins has struggled with. And, I don't think anybody does it really well, maybe Stanford, maybe, Penn, but there's a huge opportunity, but it requires researchers, and clinicians, and engineers, and programmers, and coders, and marketers, and investors working better together. And I think people still work in their own, little narrow, avenue of expertise, and got to get better, because there's a whole lot of value that could be created based on what's been learned here at Hopkins.
Thanks. Yeah, my colleague John Krakauer, I think, has left the room. This is his perfect opportunity to go on about how there's no way you're going to solve real problems if you don't have engineers in the space where the problem is.
He was the one at our table that made that point.
Okay, excellent. I'm glad I've got him pegged. I think that's a really kind of an interesting direction for all of us to think of is, how would you actually create an idea space around engineering for older adults where you really could, in a sustained way, both learn about the problem space but also understand how to create solutions that are amenable to real scaling, either commercially or otherwise. But I think that, to me, that's one of the takeaways definitely from our discussion, and I think from the other it sounds like as well. Any other comments on industry? All right, test beds and innovations in test beds. That's you.
All right. My name is Brad Fain, Director of Georgia Tech's Home Lab. We discussed a number of different things regarding the test beds, but one of the things that came out of this was the test bed as the on-ramp for innovation approach, right? How do we bring together older adults, the health system, designers, and industry, as well as the payers, in an independent, objective way of evaluating and identifying new opportunities, evaluating those opportunities, and then realizing and validating those opportunities in a prototype. We also talked about the need to objectively capture the needs and the voice of older adults, so providing an ability for older adults to communicate back to the community what works, what doesn't work, what their unmet needs are, and their aspirations and their goals. And then having researchers there that are able to see beyond what people are telling them, right? It's through observational research, through documenting unmet needs and so forth. Better definition of measures, metrics, and definitions of observables. Just because the community can't even agree on what sleep is, right? So how do we need to define something before we can agree to measure it.
That's a very engineering way to look at it.
Coming up with objective, as possible, evaluation measures of interventions, right? How do we measure in real life situations over an extended period of time whether a solution is likely to work or not? It's not sufficient that it works in a lab or that it works within the first few weeks of someone's using it. It has to be embedded in the home and prove that it works over a longer period of time. Go through that entire process of adoption to determine. And then coming out with scalable managed user populations, a way of sharing data from multiple locations, whether it be at Georgia Tech and at Johns Hopkins and so forth, so that we can combine efforts to solve some of the bigger problems that we're trying to address, so that we can share the same data. A systems-based test bed, which caregivers and health providers and older adults come together and look at it from not just the home perspective, but how are they existing in this larger ecosystem, and what are the problems that they face there. We need long-term research studies to try to capture those transitions from different levels of care that's needed, to be fully independent, to home care-based assessments, to assisted living, to nursing home, and following the family through that entire process so that we can better understand those transitions in terms of needs. Someone brought up the idea of matchmaking for older adults, and I'm pretty sure that didn't go where you might think it went, but it had to do with how do older adults complement each other's abilities so that they can rely on each other. Right? If someone has a skill in one area and that is a need, then they might have some relationship that can be established there. Looking at our student population, a test bed might be a good opportunity for building empathy within students by allowing them to go to homes and conduct research on their own so that they better understand the real world problems that older adults face. And then time when we talked about coming up with metrics of quality of life based on the discussion we had earlier about positive psychology, and how do we know that our interventions are truly having an impact on quality of life by coming up with ways of measuring. That's it.
Thank you. I mean, in some sense, the notion of test beds and some of what you're talking about, I guess, gets back to the industry discussion, right? And in that, what we're all looking for is a concrete space where you can learn, you can conceptualize, you can invent, and you can test. And how you kind of span that ecosystem is incredibly challenging. It is interesting to think that at some level, if you're fledging an app, it's easy to basically do that in the wild and get literally thousands of users quickly. But the closer you get to intimate contact with a real person, the harder it gets to do that sort of testing and scaling. And if anybody has any great ideas on how we can bend that curve, I think that would be an incredible advance for the field. Any other comments on test beds? Sounds like it was a good broad-ranging discussion. I noticed we had 2 test beds with older adults and caregivers. Was there a second test bed table or, Jeremy? Test bed V2.
Yeah, so Jeremy Brown, assistant professor in the chemical engineering department. So we spent probably the first 10, 15 minutes just kind of throwing out different solutions and innovations, kind of going with the first part of the title here. Only to cycle back and then kind of ask ourselves again, what is the problem that we're trying to solve? And one of the things that we kind of all agreed upon is that when you talk about caregivers, there are many different types of caregivers. It's a wide spectrum, from in-hospital caregivers to in-home caregivers. Even could be self-care in some respects. And so how do you uniquely define the problems of any one set of caregivers? And then try and wrap that into a test bed that allows you to, let's say, innovate in that space. It becomes particularly challenging. So one of the things that we all, kind of agreed upon is that there's an importance of having some sort of metric as to, how do you define what is the need, what is the critical need in order to then innovate in that space. How do you think about, making changes or coming up with creative, let's say, solutions at a policy level and then figuring out how they affect individuals. Because it's, you can come up with a solution for a single individual, but when you try and aggregate that in some ways, it may not scale appropriately. So how do you think about that? As you can see, we're starting to come up with a lot of other questions around this, more than solutions. The one thing that when we started talking about test bed, one of the ideas, one of the let's say thoughts that was brought up is that in the technology space, you kind of get this weird, I don't know if you would call it dichotomy, where a lot of the, due to the ubiquitous of computing, a lot of your, let's say, app-based type of technologies are, rapidly developed, rapidly deployed. When you start talking about technologies that require real hardware interfaces, they might have much longer timelines, right? And so how do you package that into the same, let's say, test bed, where you're trying to do user interface app kind of stuff at the same time that you're trying to do hardware things? And the minute you finish your hardware solution, somebody brought up, why would you develop a technology that uses the PDA or Palm Pilot today, right? Nobody uses the Palm Pilot anymore. So if you developed your technology around Palm Pilot, it would be outdated. So one of the things that we thought of when we talked about test beds is that it should be a living lab of sorts, where really the focus is on making the intervention agnostic to the device or the delivery mechanism. In the sense that, we're thinking about, using, technology that we have in our pockets and on our phones, on other kind of wearables, but there are also, a lot of technology, someone at our table brought up that, in developing countries, paper-based forms work incredibly well compared to the alternative. And so in some cases, it could be the same intervention, just delivered a bunch of different ways. And so how do you take that same idea and be able to package it in a bunch of different platforms so that it's agnostic of, let's say, the technology advances, whether or not that technology exists, let's say 5 years from now or not. We also talked about our tendency to over-engineer solutions in many respects. in this case, kind of with the paper-based form, but also you think about, devices. We brought up examples of things like body power prostheses or walking canes, which are very simple, from a mechanistic standpoint, but are still extremely useful, and they're still pervasively used in today's society. They don't have a single motor sensor or anything, the majority. And then, the other big thing that we're talking about is once you come up with solutions, how do you disseminate that so that everybody knows and is able to use it? How do you get it from the caregiver, whether that caregiver starts in the hospital to the caregiver at home? How do you get people to essentially buy in? And what are incentives to get people to buy into these quote unquote benefits? And so all this, as I can say, we kind of ended up with a lot more questions than we have answers to. That's kind of the direction that
All right, thank you. Yeah, it is intriguing to think about how do you create essentially a network of test facilities. I'm thinking of the rural communities across Illinois, for example. How do you create 20 different sites where there's, in some sense, a champion for innovation that could download and test something, and how do you actually, in some sense, spread the innovations across those 20 sites in a way that allows them to do that sort of testing? Interesting to think about how you get that scalability, as you said at the end. Great, thank you. Older adults, what more do we need to understand about older adults and caregivers? Was there a table that talked about that? Uh-huh.
Because we're talking about older adults and caregivers, we're going to tag team this.
Okay.
I'm Jessica Francis. I'm a postdoc at University of Rochester Medical Center in the Center for Health and Technology. So starting with older adults, some of the questions or some of the issues that we think we need to just know more about, and probably will always need to know more about. So designing technology for health among an aging population. We've said today that it's older adults are not a monolithic group, right? So how do we design solutions that apply to the many, but the many are very unique in their needs, and their backgrounds, and their preferences, and their motivations. So how to strike that balance is one big question we had. How to determine tech use and function of the technology for the aging population, so whose voice, which motivation is the most important one. When you're designing, whose voice do you listen to, which patient takes, I guess, priority when you are designing, because one thing can't do everything. Our society is aging fast. We're older than we've ever been. So how does that affect our knowledge base on aging in general? Right now, there's probably a lot of questions, new questions that we need to ask, as well as old questions that may need to be asked again, with relation to aging, with relation to evolving technology, tech acceptance across the board. And also within that, kind of determining what is an effect of aging and what might be a cohort effect. Where are the differences there when it comes to needs for healthcare, preferences for technology, and everything along those lines. Understanding motivations for older adults, not just, I think sometimes it can be easy to assume if somebody has a chronic illness. I work with people with Parkinson's. When we develop technology, it can get easy to think, well, they have Parkinson's, their motivation is to manage the symptoms, that's the most important thing. But it's a whole human being, and they have a lot of motivations for technology use, and I'm just really happy to hear people talk about gaming and doing things for fun as well, because that's going to help motivate sustained use. So just understanding motivations, not just for the technology, but what they want out of their lives, what they want to be happy, what they want out of their social networks and their connections and all that good stuff. Determining when it comes to tech acceptance and adoption, along the digital divide lines, we talk a lot about the have and the have-nots, but I think we also need to, incorporate in the want-nots. There's there's this thought process that if someone's not using technology, it's because they don't have access or they don't know how to use it or they need more training, and that's definitely true. However, there's also just I don't want it. It's not relevant to me, and I think that's important. And I think a lot of times with older adults, we may kind of remove that choice from them and just assume, no, you really just don't understand. If you understood how it was supposed to work, you would want this. That's not necessarily true, and I think we need to listen probably to those reasons why not. Some of them might be a knowledge issue, but some of them might just be a preference. And yeah, now I'm going to turn it over to Christine to take care of the caregivers.
Good afternoon, everyone. I'm Christine. I work in Hematology Core Lab right here in the basement. So as far as caregivers go, we did not come up with as many insights into them as much, but that doesn't mean they're not as important. Sorry, I'm a bit short. So they're not as, it's not that they aren't as important as our aging population. So in this case, for caregivers, we have to understand that because we're going to be having a more extensive aging population, and they're aging more, or there's going to be an older population than there ever has been, there's going to be a change in demographic of what these caregivers are. And so we're going to see caregivers who have different scope of knowledge. They're going to be even different ages. And we saw earlier that caregivers aren't just spouses anymore. They could be the individual's children, or even in our in modern era, they could be grandchildren as well. And so we need to be able to cater training towards these people. So in my case, I know my little sister has Crohn's disease, and so both my parents have been trying to take care of her. My father thinks it's very important, of course, to be sanitary, and he takes care of her very well. At the same time, when my little sister needs like IV antibiotics or something, my mother actually doesn't quite understand why it's important to have regular antibiotics given to her, just every 8 hours, every 5 hours. And so, of course, if she misses a dose, it's going to be a big deal. In other cases, too, like you're going to have to look into problems with burnout, since we all have some experience, or we work directly in healthcare. We know how dangerous burnout can be. So if our caregivers are not capable after a certain amount of time to take care of these individuals, then they're going to be alone, and that's going to really affect their just quality of life, and of course just how long they're going to be able to live. Because living by themselves is a lot harder these days. And of course, we're coming up with technologies to help support them, but since we're still moving in that direction, then we really need to give a lot more support, a lot more training to our caregivers as well. I think that's it.
That was great, thank you. Just one thing that with respect to the first, that I think is under-recognized in engineering is that we really need to define a value space that people live in, and we have to understand how you actually measure value. How do you sense value? Perhaps a better way. Like if I were to come to you and I needed to customize something to your interests and your values, how would you actually do that in such a way that I could basically pinpoint the right sort of solution space for you, up to and including, I just don't want that and I'm just not amenable to the intervention. I think it is something that we could engineer if we spent some time thinking about it. Any other responses? Yeah,
I've done research in a previous life on sort of recruiting dyads of caregivers as well as older adults, and looking at the space of what's acceptable to both parties and what's needed. And the overlap, I think we need to focus on the intersection. I'd be happy to share the paper that we have produced from that. But I would also, back to the point of creating communities, leading age and leading age partners would be more than happy to collaborate with the academic collaborators on this and help you sort of identify forward-thinking retirement communities to engage in the research as
Great.
well.
Thank you. Yeah, John.
Just to sort of echo what Maj said, and we're doing a project now on looking at toilet transfers for older adults and their caregivers in an assisted dyadic transfer. And the idea is that you need to design ultimately a dyadic technology. And I put that up on the board over there. Because we design for one, usually the care recipient to be independent. And we typically don't involve a caregiver in those interventions. Sometimes we do to some extent, but it's the caregiver focused on separately. And we need to look at that intersection of how they work together and function as a unit and what's acceptable both. Because they each have different perceptions of the entire caregiving and care receiving enterprise.
I would actually expand that to maybe even a triad, including the family caregiver and the professional caregiver, and maybe even a care provider, an organization from the management perspective, because they have a slightly different perspective, especially on awareness of regulations and awareness of reimbursement or payment streams. So that's my 2 cents worth.
So we need to create a clearinghouse of stakeholders.
Well, exactly. You mean maybe a
Right.
square.
More,
Yeah.
it's everyone that's
Yeah.
involved in the problem.
All right, I see a diagram emerging out of this. Somebody write it down.
We've been working on it.
Yeah. All right, last but not least, barriers and needs related to integrated systems. Was there an integrated systems group that wants to report? Excellent.
Well, hopefully you can hear me. So I'm Abigail Woolridge, I'm from University of Illinois, Urbana-Champaign. Our group was very enthusiastic. In fact, we came through the last sleeve, so I'm sure if I miss something, they will jump up and chime in for me. So the first thing we actually talked about is clarifying our definition of what a system is, and it turns out some of us had slightly different perceptions of a system, from an integrated technology system or a socio-technical system that involves people as well as technology. So we spent some time talking about that, but also when we were talking about systems, we talked about that there were challenges with what the scope of the system is and when systems overlap, so a system of systems, as you brought up, and also that systems particularly related to health and healthcare are complex. They have emergent properties that we can't fully predict, like safety or trust. And that systems have multiple components, each of which could have a potential solution to better integrate them, and that these solutions and components interact and affect each other. So we need to consider those impacts as well as overwhelming potential users. And then we talked about business influences on systems, some of which I think were touched on in the industry group, such as who owns the system, are they proprietary systems, who owns actual data from them, and then do businesses that design these systems just use buzzwords about being integrated, or are they actually truly integrated? We talked about when we're studying systems or trying to design integrated systems, we need to have a deep understanding of the problem, which includes actually identifying the problem, which you just heard about. This usually is an applied process. It's a long, experts have to be embedded, and we need people with various expertise. It's a multidisciplinary project, right? And this includes identifying and reaching out to a variety of stakeholders, including the aging adult or the patient, the person, their family, formal caregivers, other healthcare professionals that should be included in developing a deep understanding of the problem from multiple perspectives. Touching back on the varied expertise, we talked about this a little bit more. To solve those problems, once we understand them, we're going to need multiple expertise. Models can be useful to help us communicate. We talked about the socio-ecological model, the SEEPS model, a couple others, and that also helps give experts language to talk about problems together.
We touched very briefly on some regulatory concerns about developing systems, like who's going to pay for it? Is it going to be a national level strategy? Is that possible in every country? We didn't really think so, but could be wrong. Also, how are we going to hold people responsible or accountable for these systems? In other words, how are we going to measure their outcomes? And then we went back to the merger of property systems and spent quite a bit of time talking about trust and security in the system, particularly in a vulnerable population that might be targeted for to be taken advantage of. Miss anything?
Great, thank you. Yeah, I wish I had a wordle of what everybody had said, because I think who's going to pay for it has now come up in just about every panel that's come out. Thank you for your thoughts. Any response to that? Yeah.
Just to tie two different concepts together we've been talking about, is systems view and test beds. So there's a lot of issues that involve the interdisciplinary work within a test bed using a systems point of view. So how do you work out thoughtful mixing of different methods, methodologies, research designs?
Mm-hmm. Okay, now you get to repeat it for the microphone.
Oh, try that again?
Yeah.
Oh, okay. So I was trying to link the concept of a systems view with what we talked about today in terms of interdisciplinary research and test beds, and how, what does it mean to have a systems based test bed? How do you thoughtfully combine different types of data, different philosophies of evaluation, research designs? I have no answer.
Mm-hmm.
Seems like something that needs to be worked out.
Mm-hmm.
Project by project.
Absolutely. Imad.
When it comes to who pays for them, even if you have the same population with the exact same issue, sometimes you need to know whether they're low income and eligible for Medicaid, where they live. Do they live in a state where there is a Medicaid waiver program, for example, that may pay for some of these technologies or technology-enabled services? Are they a regular Medicare or a Medicare Advantage, and so on and so forth. So it's a really complex problem, but we have, again, we have done, Leading Age has done an analysis of Medicaid waiver programs in all 50 states, and we've also, for 7 categories of technologies, we list the types of payment sources or assistance sources that are available on the technology selection tools that we've developed.
Mm-hmm. So that'd be a key element then in these test beds, is to actually have your periodic table of who will pay for what, where, when, why, and how.
Exactly, when you're recruiting sort of targeting, and that's why I emphasize the importance of engaging payers potentially, whether it's private payer, Medicare Advantage plans, for example, or Medicaid offices.
Mm-hmm. Great, thanks. Press, looks like you have an extemporaneous comment.
Well, it's not brainy. One thing about systems is they're systems of systems of systems. They're, in a way, systems all the way down. And, you know, in listening to the discussion today, one of the challenges is the whole problem is so enormous. It's basically a big chunk of our society that's getting bigger and I'm becoming part of. And I often wonder how much progress we can really make by saying, here's the whole problem and you have to solve it all at once. In a way, as a society, we do. But I think one of the things about systems that is important is you've got some kind of decomposition into smaller chunks that interact with each other. But the problems of each chunk can largely be addressed on their own with some regard to how they interact.
Mm-hmm.
So, you know, thinking back to test beds, you can imagine picking as a test bed maybe a nursing home or an elder community or something smaller like a family. And I think moving forward and trying to structure research, I think one of the things that is going to be a challenge for all of us, is to have some understanding of how this all decomposes and fits together, but then pick some chunk where we can make some progress.
Mhm.
And it's a general observation. If I was smart enough to know the answer, I would go write your ERC proposal for you. But I do think it's something, just listening to the whole discussion today is something that maybe is worth us all thinking about a little bit. Where are the chunks within this wonderful picture that we can actually bite off something and make progress that will be useful for someone?
Mhm. Yeah, thanks, Russ. No, it's a very, basically the short version is we can't boil the ocean. Let's find the right place to start.
Yeah, maybe we can boil McGilligut's pool.
Yeah.
Connects to the ocean.
All right. Yeah.
I said I have a lot of opinions, I do. But the last topic about systems, I think of this as the technology and it's the way people learn how to use the technology and then use it. And you got to remember that what we're talking about is a human being who's a primary care physician or a nurse or overworked, overwrought caregiver or confused older patient with chronic conditions. And it's about their problem, it's not about your technology. It's about making their life better, not only with your solution, but trying to figure out how to use their solution. And I think the healthcare system right now is feeling pretty skeptical, if not cynical, about technology, because the healthcare system is still trying to work through a poorly implemented EHR, which seemed to ignore the user experience. So I think, we're like, if you bring me some new solution, you better figure out how I can easily learn it and then use it, because they're skeptical about that.
No, you're absolutely right. Thank you.
We can pop back up here. So that was part of our discussion about the system has multiple components, right? So one example is the environment. You can redesign the environment that affects somebody's activity that then affects their health. It may not have to be a technology. Because as you said, certain populations are a little technology intervention shy right now due to things not working.
All right. Excellent. That was a great discussion. I thank you, everybody, for taking notes. Let's give everybody who spoke a quick hand here. All right. What I'd like to do is, the last bit of today is, up till now, we intentionally built the program around let's understand the problem space. But we thought we'd add a little bit of, well, let's peek over the edge into what are people thinking about in the solution space as well. So we invited 6 speakers to talk just briefly about innovations that we're working on. So if I could invite them to come up, I forget which order they're coming up in. What I was going to suggest is while they're doing that, we've been sitting for a while, so everybody stand up and shake it out a little bit, but don't leave the room because it'll be hard to get you back in again.